pre and postmenopausal. Yes.
Doctor, thank you, Professor. About reversed axillary mapping,
Yes.
actually, we have been trying this in a current study in Cairo University. We faced the problem that if the axilla is positive by ultrasound and we decided for axillary lymph node dissection, usually we find the blue lymph node when we inject in the subcutaneous tissue in the arm within the domain of the breast lymph nodes. That's in situation when it is positive by ultrasound and we decide dissection.
Yes.
However, if we decide sentinel lymph node biopsy for an early stage of breast cancer and we inject the blue dye in the breast, and then we decide according to the ACOSOC criteria to go for dissection, we can't inject the blue dye anymore because the
Yes.
blue dye is present. So in practice, we didn't find it very helpful. So
Yes.
I'd like to know what's your impression about this.
Yes, no, that's a good point. You know, if you do dual mapping in the breast, obviously you can use the same dye. Our plastic surgeons that do the lymph procedure, they inject different dyes. So they inject them in different parts of the arm, both dorsal and the ulnar side. But it is competing if you inject the same dye. Now, there are also some other dyes for lymphatic mapping that we're starting to use. We're starting now to trial the MagTrace, which is a magnetic SPIO, with some brown dye, which actually can use to do the mapping, and that doesn't compete, for example, with a blue dye.
All these can be done on academic or experimental purposes, but we can't use it in routine practice. Like sentinel lymph node biopsy, it got its importance because it's easy to do, and any hospital can do the setting for sentinel lymph node biopsy. But magnetic tracing or radioactive isotopes are not available in every place. So
Yes.
that's I'm telling, we can't depend on the reversed axillary mapping
Yes.
as a solid method of avoiding lymphedema and decreasing the rate of lymphedema.
Yeah, no, I appreciate that, and you know, if obviously there's not available, I mean, there are other dyes as well. Androcyne in green, you can inject in the breast potentially and do the blue dye in the arm, or vice versa. It's just a concept, but in general, I think it's fair to say that there is a bit of distinction in the majority of the cases between the drainage from the arm and the drainage from the breast. Now, those lymph nodes from the arm don't get so much in the way when you do sentinel lymph node biopsy, although they could be injured, but certainly they get more in the way when you do an axial lymph node dissection. So you potentially can injure them. And so that's the concept. And the concept of the reverse mapping I didn't mention is that if you identify a node and you have to remove it because it's part of your sentinel lymph node biopsy, but it's still blue, then you can anastomose or approximate the lymphatics that you take out. Now, how well that will work is something that the trial is looking at. But it's not exactly lympha where you anastomose it to lymphatic, to venous branches. It's reapproximating the lymphatic close to each other.
Last question, Dr. Hamdi. Thank you very much for such a comprehensive talk, which is very interesting, and interesting lectures raise question more than answers. I'm asking about the whole concept of the sentinel node. You clearly demonstrated that there is a trials of avoiding sentinel lymph node biopsy. Does the statistics that showed that the incidence of non-sentinel nodes, the AMOS trial 33% and the other trial 44%, help in that?
Let me make sure I understand the question.
I'm saying that with the two trials, AMOS
Right.
and the other, there was 33% non-sentinel
Yes.
positive, and the other one 44%.
Yes.
Will that help in avoiding the sentinel lymph node technique altogether?
Right. Obviously, you know, good patient selection is paramount for the trials that are already ongoing. And as I mentioned, despite of the fact that they include T1 and T2, most of the patients that get into these trials were T1. Okay? Because obviously we know a rule of thumb, I tell my patients, for every centimeter of tumor is about a 10% chance of axillary positivity. You know, so like 2 centimeter tumor is about 20%, 3 centimeters close to 30%. So it depends on what type of patient you put in these trials. And by definition, I think these trials have low risk patients. So you obviously have to prove that concept in patients with very low risk to tell you that leaving disease behind in about 10, 15% of the times, either axillary breast radiotherapy or systemic therapy would be enough to control it. But patient selection is key. And we're not there yet. I think we have to see the results from these trials, see how they apply to different groups of patients. And obviously, the next day, you're not going to get a 6-centimeter tumor and trying to not do a sentinel lymph node biopsy, but you probably do it in somebody that has half a centimeter or 1 centimeter, centimeter and a half tumor with favorable biology. And of course, if the trials are supportive of the concept that local recurrence and disease-free survival is not affected. So we're not there yet. I want to make that clear. I think we're still, and as I said, the other part of it is one thing to talk about local control, but the other thing is what information do you need to treat? And I didn't get into the great detail, but radiotherapy for patients with positive nodes, at least in the US, is becoming very standard. Even with 1 or 2 positive nodes, we typically will radiate the patients. We may not have to dissect them, but we radiate them. And the question is, do you need to know if those nodes were positive to make decisions in terms of radiotherapy and, of course, systemic therapy, as I mentioned before.
Thank you. Thank you, Dr. Now, can we move to the second?
Yes. Thank you. So,
Operational management after neoadjuvant chemotherapy with dose of evidence support.
okay, thank you. So we're going to talk about local regional management now after neoadjuvant chemotherapy, and purposely left all that for this talk versus the first talk, and what does the evidence support. And of course, we know that neoadjuvant chemotherapy was originally utilized to convert patients for inoperable locally advanced breast cancer to surgical candidates. And then we've run several randomized clinical trials comparing neoadjuvant to adjuvant chemotherapy to find out that essentially the effect of chemotherapy is the same whether you give it in the neoadjuvant or the adjuvant setting. And as a result, neoadjuvant chemotherapy became a reasonable alternative to adjuvant chemotherapy based on these randomized trials for patients with large operable disease. And we know that neoadjuvant chemotherapy offers some potential clinical advantages over adjuvant chemotherapy in appropriately selected candidates. And we also have learned through the randomized trials is that achieving a pathologic complete response, which is essentially the elimination of invasive disease from the breast and the axilla, is a surrogate endpoint of neoadjuvant chemotherapy efficacy. And patients that achieve a pathologic complete response have significantly better outcomes than those that do not. And as a result, again, this is an...
Please, slides.
Oh,
Slides.
sorry.
Slides.
The slides are not showing. I didn't- Oh,
Slides.
thank you.
Okay.
Thank you. So, so as a result, pathologic complete response is a surrogate endpoint of neoadjuvant chemotherapy efficacy that has actually led the US FDA to use pathologic complete response to approve new drugs as an accelerated approval, waiting for the adjuvant trials or longer outcome neoadjuvant trials to fully approve these drugs. And this has happened already. We also know that pathologic complete response rates vary by subtype. For patients with hormone receptor positive HER2 negative breast cancer, particularly grade 1 and 2 in the overview analysis by Pat Cortazar, we see very low rates of pathologic complete response of 7%, and for those with grade 3, about 16%. And then on the other side, the triple negative patients on the right side of the screen, about a third of the patients had a pathologic complete response. In the middle, we see the HER2 positive patients, and in the overview analysis, included trials that did not administer anti-HER therapy and those that did. And where you see the pathologic complete response in hormone receptor positive, HER2 positive patients without trastuzumab, in the trials without trastuzumab, was very similar to the high-grade hormone receptor positive, HER2 negative to the left. Similarly, for hormone receptor negative, HER2 positive, the pink bar, had about a 31% pathologic complete response rate without trastuzumab. But you see what happens when anti-HER therapy was given, both in triple positive, as we call them, and in the hormone receptor negative, HER2 positive. Pathologic complete response rates went from 18% to 30% for hormone receptor positive, HER2 positive, and 50 versus 31% for hormone receptor negative, HER2 positive. So clearly, the landscape of pathologic complete response is changing as we develop more active regimens in different subtypes. And over time, of course, we have seen a significant increase in pathologic complete response. When we started with neoadjuvant chemotherapy trials, CMF was the chemotherapy that we used, and pathologic response rate was very low, 7 to 8%. Then with anthracyclines, we essentially doubled that. We also doubled it with the taxanes. And then in HER2 positive, as I mentioned, we went to about 40 to 45% with chemotherapy and trastuzumab, and then almost 55 to 60% with chemotherapy plus dual anti-HER therapy. And on the last couple of bars, in triple-negative breast cancer patients, when we added carboplatin to anthracycline taxane-based regimens, about 50 to 55% PCR, and with the addition of checkpoint inhibitors, almost 65%. So from a surgical standpoint, our medical oncology colleagues have actually rose to the challenge and has given us an opportunity to actually not find disease much when we do our surgery. So how can we take advantage of that, of these developments, and help our patients in terms of reducing the extent of our surgical approach? So how can we maximize the impact, the clinical impact of neoadjuvant chemotherapy in the area of precision medicine? Identify better predictors of pathological complete response, and I showed you some already, baseline biomarkers or potentially changes in the biomarkers as the patients undergo neoadjuvant chemotherapy, and use pathological complete response as a surrogate endpoint to in selected subsets such as a potential pathway for drug approval, but more importantly, use the primary tumor response as a guide to individualize decisions of locoregional therapy as well as systemic therapy. And for the purposes of this talk, of course, we'll focus on the locoregional therapy, not on the systemic therapy. So tumor response to neoadjuvant chemotherapy as a guide to individualize decisions of locoregional therapy. Well, we first focus in the breast tumor, right? The whole idea was to convert patients from inoperable to operable candidates, to convert mastectomy patients to breast-conserving candidates, conservation candidates by shrinking the tumors. But also, as surgeons will know that if you operate on a smaller tumor, you potentially give the patient a better cosmetic outcome. So even if the patient was a candidate for breast conservation, but it had a 5-centimeter tumor, you can probably do a lot better cosmetically if you shrink the tumor to 1 or 2 centimeters or almost down to nothing. Now, the challenges with this is we need to know how the tumors shrink in response to neoadjuvant chemotherapy, how do they grow and how do they shrink. And this is a slide that has been shown many times, and it's Bernie Fischer is the one who actually came up with this, is do the tumors shrink in a concentric pattern, as you see on the left side, or do they shrink in a sort of honeycomb or patchy pattern where islands of tumors may be left in the breast even if the tumor became non-palpable. And if you did a lumpectomy and the shrinkage is on this pattern, then you'll be very successful. You can do a small lumpectomy and your margins were negative. But if you do it in the second situation on the right, we see that potentially you can find residual disease in the island, in the tumor bed area where your margins may be compromised. Now, we're not sure why some tumors shrink one way or the other, but we have some hints. The proliferation of the tumor and the subtype of the tumor actually can point us into one direction. Usually triple-negative HER2-positive highly proliferative tumors shrink on the left pattern, and more ER-positive HER2-negative low proliferation, low grade may shrink the other way because chemotherapy is not effective for those patients and it may leave islands of disease where the tumor used to live. So it's important to identify the pattern of shrinkage and the extent of disease after neoadjuvant chemotherapy. Breast MRI is actually a very good way of doing that, in addition to mammography and ultrasound. So we typically do triple imaging if we can for patients. We do mammogram, ultrasound, and MRI before and after neoadjuvant chemotherapy if we're going to consider breast conservation. And of course, the other challenge is to identify where the tumor used to live when there is not much evidence that the tumor is still there. This is a patient with a very ill-defined triple-negative breast cancer on the left side. Before neoadjuvant chemotherapy, you see a little parenchyma thickening. And then, of course, after neoadjuvant chemotherapy, you see nothing. And how can you be accurate of where the tumor used to live? Of course, we put clips when we biopsy. In the US, at least, we put clips in everybody. Even if it's a benign biopsy, the clip stays there. And we localize these clips and remove them. And normally, we did that with wires, put wires in the breast and remove them. Now, at least by far, we've switched into wireless systems. Whether all those are available where you practice, that's another question. But certainly, we have ways of putting radioactive seeds, with Saviscout, which is a radio frequency reflectors, or magnetic seeds to know exactly where the previous biopsy took place, so to go and remove the area to prove that the tumor is gone. One question we adopt in less surgery after neoadjuvant chemotherapy is the fact that most of the studies have shown a small, but in the overview analysis, significant increase in local recurrence for patients that were mastectomy candidates and downstage now to breast conservation. This is in the range of about 3%, but one element that needs to be taken into account is when you look at all the neoadjuvant versus adjuvant trials, in some of the trials, patients that responded to neoadjuvant chemotherapy were randomized to neoadjuvant chemotherapy responded, did not go to surgery. So they just were radiated, particularly some of the French studies. And when you include the studies in the overview analysis, you see a bigger rate of local recurrence if you did not formally do surgery. So when we actually split the groups to, on the left side, where surgery was performed in everybody after neoadjuvant chemotherapy, versus the trials where surgery was less commonly to be performed, we see that those that surgery did not take place because they thought by imaging the tumor went away. Obviously, the local recurrence rate was significantly higher. But when you look at on the left, we see that it's about a 3% difference. And that's expected by the biology because these two groups include different patients. The group that had breast conservation after neoadjuvant chemotherapy includes patients with bigger tumors that were shrunk to be put in that group. Nevertheless, it's important to discuss that with patients to make an informed decision. So that was the first focusing on the breast tumor. But after that, we realized that we can possibly do the same thing in the axilla, because the reduction in the extent of axillary surgery by downstaging involved axillary nodes performed in sentinel lymph node biopsy was something that was very attractive. Obviously, before sentinel lymph node biopsy, even when we downstage patients, we still did an axillary dissection because that was the only thing we're doing. Also, there's a concept of trying to reduce locoregional radiotherapy by downstaging tumors in the breast and the axilla, and the potential for even eliminating altogether either surgery or radiotherapy from the breast. So we'll discuss a little bit about that. Again, we have shown in the randomized trials that you can downstage the axilla. About 30 to 40% where anthracyclines and taxanes were used before or after neoadjuvant chemotherapy. And of course, now with more active regimens, as I showed you, we can expect up to 70 to 80% of the patients in selected subtypes like triple negative and HER2 positive, if they have positive nodes before, to have negative nodes after neoadjuvant chemotherapy. Now, when you try to apply sentinel lymph node biopsy in this setting, there's two concerns that you have to take into account. They're theoretical concerns, but they're real. The first is the anatomic concern, and that dictates that if tumor involvement of the sentinel nodes and scarring occurs because of the tumor, and then regression of the tumor after with a lot of fibrosis, maybe the pathway is altered and another group of nodes become the sentinel nodes. The second concern is the biologic concern, and that is that tumor regression in the, with neoadjuvant chemotherapy may vary in the sentinel nodes versus non-sentinel nodes. Maybe non-sentinel nodes are more resistant because they're second and third tier nodes, and we cannot necessarily assume that if the sentinel lymph nodes were negative, the non-sentinel nodes will also be negative. If either of those occurs, then the false negative rate of sentinel lymph node biopsy after neoadjuvant chemotherapy will increase. You would agree with that. So let's look and see what happens actually in clinical practice. So when it comes to decreasing the extent of axillary surgery with neoadjuvant chemotherapy, first, it's fair to say that this concept is currently applicable for patients that have operable disease. We don't want to apply this concept to patients with inflammatory breast cancer, T4 disease, N2 and 3 disease with matted lymph nodes, because we don't have good safety data on the performance of the sentinel lymph node biopsy. Ultrasound of the axilla is a very important tool for patients that undergo neoadjuvant chemotherapy, very simple, minimally invasive technique, gives us useful information and avoid a sentinel lymph node biopsy, and can demonstrate actually direct chemosensitivity by marking the lymph node that was involved before and then retrieving the lymph node with a clip to prove that that lymph node became negative. And as I will show you, this is an approach that actually reduces further the false negative rate. So how do we manage patients that present with clinical N0 disease in the axilla and they're candidates for neoadjuvant chemotherapy? Well, there has been a lot of debate. Do we do the sentinel node before neoadjuvant chemotherapy or after? And just to put that to rest, pretty much now everybody agrees that waiting and doing the sentinel lymph node biopsy after neoadjuvant chemotherapy is the way to go, because this approach capitalizes on the downstaging effects of neoadjuvant chemotherapy, converting positive nodes to negative nodes and doing less surgery afterwards. There have been several studies and meta-analyses that have shown no difference in the identification rate after neoadjuvant chemotherapy, or false negative rate, with rates, for example, as you can see, 96% identification rate, and the pool false negative rate about 6%, which is very similar to what we see with upfront sentinel lymph node biopsy. So for patients with clinically negative axilla, we like to wait and do the sentinel lymph node biopsy after neoadjuvant chemotherapy, and it works equally well. What about patients that present with clinically involved axilla, and then we biopsy the axilla, and the nodes are now positive? How do we handle these patients? Obviously, these patients, if they had surgery first, should go to axillary lymph node dissection. But is there an opportunity to downstage the disease with neoadjuvant chemotherapy and potentially save the axilla from a full axillary dissection? So as you know, there have been 4 prospective studies reported in this, several retrospective studies as well, the Z1071, the Sentina, the Canadian SNF-NAC trial, and the GANIA-2 French trial. All these trials essentially took patients with positive nodes documented by biopsy, neoadjuvant chemotherapy, clinically negative axilla after neoadjuvant chemotherapy, and then sentinel lymph node biopsy, and if the sentinel lymph node was negative or positive in this case, axillary dissection ensued, so we know what the false negative rate would be. And essentially, we were aiming for about a 10% false negative rate, but as you see from the numbers, the overall false negative rate was about 12 to 14%, 12% in the GANIA, and only in the Canadian trial was 8.4%, but the GANIA trial also, the Canadian trial also used immunohistochemistry on the sentinel nodes that increased the sensitivity of detecting disease. So it was a little bit more than we thought, and we said, yes, maybe we have to optimize how you do it because it's a little higher, but consistently in these trials, all the trials showed that if you remove at least 2 or maybe 3 or more sentinel nodes, the false negative rate dropped to single digits, 9.1, 7.3, 4.9, 7.8, as we see there. So just by the mere fact of removing more than 2 or 3 sentinel nodes, the false negative rate dropped to acceptable standards. But the question is, can we even do better? And one observation that led us to believe that we can do better was an observation from the 1071 study, where if the investigators were able to identify the clip that was placed in the node that was biopsied and retrieve the clip with a sentinel lymph node specimen, then the false negative rate was only 6.8%, but was about 19% if the clip was in the axillary dissection specimen. In other words, they did not remove it at the same time. So what the concept essentially is telling us that the anatomic concern that I mentioned to you earlier is real, that if the nodes are fully replaced by tumor, and then the tumor fibrosis at the end, the pathway changes to another node nearby, and if you don't biopsy the previously positive node, you may increase your false negative rate. And then there was an MD Anderson study actually that it was pivotal in actually reestablishing this concept. What they did at MD Anderson, they gave patients neoadjuvant chemotherapy. Those patients had positive nodes before, and they became clinically non-negative. And then they took out the sentinel nodes as they mapped them with a dual mapping. And when they did out the sentinel nodes, the false negative rate was 10.1%, which is what we have expected. And then they said, well, let's just only take out the clip node and measure that only. And what is the false negative rate? We just take the node that was biopsied before. And when they did that, the false negative rate dropped to 4.2%. And then they said, okay, now what if we counted the sentinel nodes and the clip node together? What would the false negative rate be? And as you can see, it was even further, 1.4%, which is essentially remarkable to get down to 1.4% false negative rate. But one study from MD Anderson, retrospective study, prospective, but anyways. So the reason for that was that the clip node did not qualify as a sentinel node based on radioactivity and presence of blue dye in 23% of the patients. And since then, they coined this term of targeted axillary dissection. And targeted axillary dissection means sentinel lymph node biopsy plus removal of the previously biopsy clipped node. Since then, we now have prospective evidence that this concept works very well. This is a study from the Netherlands. Now, the Dutch group actually injected radioactive iodine in the involved node, and then they did the neoadjuvant chemotherapy and then went and removed the radioactive node. That's how they did the clip node removal. And in a previous study, it has shown about a 7% false negative rate if they just removed the clip node. But in the RESAS trial here, they essentially applied the concept of targeted axillary dissection. They did radioactive iodine, then they did sentinel lymph node biopsy after neoadjuvant chemotherapy with removal of the clip node. And the false negative rate in this trial was 3.47%. in line to what we know from before. Previously, as I showed you in the bottom, in the MARI trial, just the radioactive iodine removal, it was about 7%. So a prospective validation of the concept of targeted axillary dissection. We also have several other prospective retrospective data showing us very similar rates. The MD Anderson approach was the 2%, the ELINA, the RISAS, as I mentioned, 3.5%, and the CENTA ELINA, two additional prospective cohorts, 4.1% and 4.3%. So clearly, we can increase our accuracy of knowing what happened to the lymph nodes after neoadjuvant chemotherapy by applying the concept of the targeted axillary dissection. How do you do that? There's multiple ways of tagging the nodes. You can deploy, of course, markers based on stainless steel, titanium, polyglycolic acid, and then you have to localize them to remove them after. Now, again, we used to start localizing them with wires in the axilla. That's not very easy, but with a wireless system, it's very easy to localize either with the magnetic seeds, with radioactive seeds, or with a radio frequency. If you don't have that ability, you can also use a carbon or black ink tattooing that you can put before neoadjuvant chemotherapy. It stays there in the lymph nodes. And of course, the radioactive iodine, as they did in the Netherlands, or ferromagnetic seeds are other ways of approaching that. Now, ultimately, to validate the concept of doing neoadjuvant chemotherapy and then do just sentinel lymph node biopsy and not completion axillary dissection, which we do now a lot if we do the targeted dissection, is the local recurrence rate. Is this going to be increased? And so far, prospective and retrospective trial data, as you see on the right side, has shown very low rates of axillary recurrence. Now, the follow-up is different. As you can see, some follow-up is long-term, 108 months, some others only 2 to 3 years. But certainly more data are needed. There are prospective studies that assess that. One was reported in San Antonio with early follow-up. So we see that actually the local recurrence rate is actually very low. And that will be the ultimate endpoint for adopting the approach of not completing the axillary dissection if the lymph nodes became negative. On the other hand, what happens if the nodes are still positive? Well, to make a long story short, there's several papers now, a bigger one from Mori and Sloan Kettering, showing that even if you have microscopic disease in the sentinel, like micrometastasis or even isolated tumor cells, the risk of finding additional lymph nodes in the axillary dissection specimen is pretty high. And for micrometastasis, about 2/3 of the patients have additional disease. As opposed to the upfront setting, where you have just micrometastasis in the nodes, only 10% of the times you have non-sentinel lymph node positivity. Now, for the ITCs, it's still a very low number of patients. 70% had non-sentinel nodes, but it's only like 6 patients in that group. So what do you do if your sentinel node is still positive? Nowadays, the standard is to complete the axillary lymph node dissection until we get results from prospective trials to say that maybe it doesn't matter. And one such trial is the Alliance 11-202 trial in the US that took patients with clinical T1, T3, N1 by biopsy, neoadjuvant chemotherapy, and then clinically non-negative. They did sentinel lymph node biopsy, but if the sentinel node remained positive, then they randomized patients to completion axillary dissection or not. This trial is completed accrual, and in the next couple of years, I think we'll be hearing results. If the trial shows that it doesn't make a difference in terms of local recurrence and long-term outcomes, I think we can eliminate another group of patients that we need to complete the axillary dissection, those that remain positive after neoadjuvant chemotherapy. And then the last topic, very briefly, is to whether we can avoid surgery or radiotherapy in patients that achieve a pathologic complete response. There has been a lot of discussion over the last few years. Can we predict if there is residual disease in the breast? Can we do that with imaging? And the answer is we can, but not very good, even with triple imaging, about 85% accuracy to know if there is no residual disease. Or can we add a vacuum-assisted core biopsy in the tumor bed to predict if there's residual disease? And there have been some retrospective studies, some suggesting a higher false negative rate that you see on the left, 49%, some suggesting low false negative rate. In other words, getting negative results on the core biopsy by having disease when you go to surgery. And so we weren't ready for this in terms of retrospective studies, but we put it to the prospective trial test. And there have been 4 prospective studies reported in San Antonio at the same time in 2019. And one was also the NRG BR005, the group I work with. And again, seeing that false negative rates were not what we expected them to be, about 31%, 18%, 37%, 22%. So we could leave residual disease in a substantial proportion of patients. And that doesn't only have implications for local control, but it has implications of giving them appropriate systemic therapy after neoadjuvant chemotherapy, because if you still have residual disease, you can change your treatment and do better. So to make a long story short here, the accuracy of imaging and imaging plus minimally invasive core needle biopsy in identifying residual disease has not yet been convincingly demonstrated. So we really need to actually either redemonstrate this concept in a more selective approach,